Very much, Molly, and thanks also to Adele and Andrew for inviting us to present. So, as Molly mentioned, this is a HRB funded project that we're going to be describing to you, and I'm delighted to be co-presenting with Ciara. The way I get around struggling with the pronunciation of Ciara's last name, we have two Ciaras, one is Ciara K and the other is Ciara D, and that makes it much easier. So, and I'd also like to welcome other members of the young adult panel who are here today. So when I talk to our junior doctors in the hospital, those who rotate through our department, I encourage them to present cases that they're not maybe proud of, or cases where things don't go that well, because I think there's much more learning from for yourself and for the audience. And I would have to say at the outset that although I'm one of two consultants involved in leading our young adult work in the Diabetes Centre in Galway, I struggle every time I do a young adult clinic. I think this isn't working well, and the way I would, we have 30 to 50% non-attendance at our clinics. That's, to me, that I don't need to say any more. If you had that degree of non-attendance at any other clinic or any other forum, you would say to yourself, this is broken, this isn't working. And that's what we've been trying to do over the past 3 to 4 years now. As the title slide suggests, we're trying to reimagine diabetes care. I can tell you it's not easy. We tend to do things the way that we have always done them, and that's true in a busy hospital. It's very hard to go back and say, well, if we were starting again, how would we organize care? But that is the challenge. So what I'm going to do in the next 10 minutes or so is I'm going to give you a very brief primer in type 1 diabetes. I'm then going to describe some of the challenges in delivering diabetes care to young adults as I see them, describe what we're funded to do by the HRB in our study, and then I'm going to introduce Ciara, who will talk about her involvement in our young adult panel and her involvement in this research right from the early days of it. So if you want an interesting read, probably the greatest biomedical discovery of the 20th century was the discovery of insulin. This is a Canadian historian telling the story and telling it really well. It's a remarkable story. So type 1 diabetes was a fatal condition before Banting and Best discovered insulin. It wasn't that long ago, 1922. I tell our summer students who work with us for projects over the summer, it was the greatest summer project of all time. So Charles Best worked for a summer with Frederick Banting and got the Nobel Prize 2 years later. And I kid you not, that is a fact, So 3 reasons for treating diabetes. Seems like a strange question. Why treat diabetes? Prior to Banting and Best, it was a fatal condition. So we treat it in order to prevent people from dying. That's easy enough to accept. The symptoms associated with high blood sugar, I'm conscious of avoiding jargon after our earlier speaker, but polydipsia and polyuria means drinking a lot and peeing a lot, and it's very unpleasant, okay? And so we treat to get rid of unpleasant symptoms. The third reason for treating diabetes, which really only came to light after the discovery of insulin, is that the closer your blood sugars are to normal, the healthier you are in your life with diabetes. But that is a difficult to take on board, I think. I don't have diabetes, but I think this would be hard. So we ask people to do this several times a day, to do this several times a day, to get what? To get what they have already, which is good health. So we ask them to do an awful lot with, you could say, little gain. They just get to keep what we all take for granted, which is good health. So I think that third reason for treating diabetes is at the heart of where the difficulty lies in terms of people with diabetes, and in particular young adults, getting their head around it. Yeah, that's my take on it. Others can comment. This is a record book. Those of us who work in diabetes care would be familiar with this approach. Can I see your record book? Or do you want to see my record book, doctor? And this was dog-eared and dirty and blood-stained and very real. Most of the numbers were written with different coloured pen or pencil, and so it was clearly being used. The HbA1c, which I'll come back to for those of you familiar with it, a blood test that we use to tell whether a person is good or bad. The A1c here was about 8.5%. This literally happened. This was one young adult coming into me when I was working in the UK. This was the person who came in after her. And this was absolutely pristine. Yeah, this record book was not dog-eared or dirty. Every number was written with the same pen, in the exact same orientation. And if it were in a bookstore, it would be in the fiction section, yeah, because it doesn't reflect. And the A1c here, to give you an idea, was 11.5%, which is really, very poor blood sugar control. So do you bang your fist on the table and say, what the hell is going on here? Or do you try to understand what's behind this record book? So Bob Anderson is a clinician, psychologist in the States, and this is his take on it. I think this slide is unfair. So he says you have choices, you make decisions, and you live with the consequences. What's missing, I think, is the skill set that we have to give people to manage the condition well, and also the education and the orientation to making the choices informed. Yeah. So that's what we've been trying to do, trying to understand some of the challenges. This is from, again, you met Sarah Simpkin earlier, and you heard a bit about Jigsaw, and Sarah has been a huge part of helping us to reimagine diabetes care for young adults. And I really like this slide. It just tells you there's a lot more going on in the head than just the diabetes. And it's trying to get the head around all of these things in the young adult. And the other aspect of young adulthood is that a lot of young adults living with type 1 were diagnosed as children, and they never got education. The education was given to the parents, and it's just assumed as they get older that they, by osmosis or by some, method not known to me, that they just sort of assume that, that they get these skills. So this is how we deliver care. This was me before my hair turned grey. And look at the size of the record. So this was delivering care in the UK when I lived. And so we bring people up to a hospital where it's very difficult to get parking. It's not a pleasant building. The people that work in the building in Galway are fantastic. Some of them are here, but it's not a pleasant building. And we expect people to come up on a particular day in the month that we do our young adult clinic, and I don't know, it's a wonder that it works for anybody. Our outcomes are poor. This is across the regions of Scotland, and our A1C. So this HbA1c I mentioned, it's a blood test taken and sent to the lab, and we do use it as a way of saying whether somebody is, and I mean it, good or bad, based on a blood test to determine whether we don't make allowance for the lived experience of having this condition and dealing with all the juggling that you saw in that head slide. So poor outcomes across Scotland, and certainly in our centre. This is like washing your dirty or hanging your dirty laundry out in public, by the way. Not many diabetes clinics would be happy to do this. They are in Scotland, fair play to them. And this is the scary bit, and I realise that this conference has already touched on difficult issues around death and dying, but it's not just about A1C. Our young adults have a higher risk of dying than young adults without diabetes. This is an audit of mortality in Scotland, and the orientation here, so age group, so from young to old, and having diabetes. So the median here, the one is if you're left of that, your risk of death is higher. So having diabetes at any age increases your risk of dying, and we kind of know that. But in the young adult age group, if you're a young man, 15 to 34, your risk of death is higher fourfold. If you're a young woman, it's 8 to 9-fold higher. So outcomes, including mortality, are poor. And I think that's why the HRB, we painted this picture to the HRB. This is young people dying, young people having poor outcomes. And so we've been funded to try and reimagine it. Sorry, a very brief case of a young man who nearly died. So this is real. A young man living with type 1 diabetes for about 10 years who played football, won a football match, a big event in his life, won the championship, went out and had, about 10 pints of Bulmers, and, did what his mates were doing, became unwell. One of his mates said, I know what's wrong, and knew that he could do with something from an orange syringe. An orange syringe is glucagon, which helps raise your blood sugar. He gave him the wrong orange syringe and gave him insulin when his blood sugar was already in his boots. And so his story, there's a good outcome. He did not, he ended up pulling through and got, emergency care from paramedics, and lived to tell the tale. But this stuff happens. I'm not making it up. So developing a complex intervention, trying to reimagine diabetes care is not easy. And this is the best example I've come across of a group of colleagues in the UK looking at interventions geared towards the individual in the way of education, goal setting, interventions maybe geared at the clinic, organising care differently, making it more accessible, and interventions geared towards the family. We can't have the family not part of it. They have to be there in terms of the support function. And so with our colleagues in Jigsaw, we are working to try and come up with a different way of approaching the delivery of diabetes care to our young adults. And so I'd like to introduce you now to Ciara Kay, one of our young adult panel. And Ciara's going to talk about her involvement with the work.
Hi there. So as Professor Dean said, I am one of the young adults involved in this project, and from the very onset of this project, involving young adults in the research was one of the main priorities. So in February of 2014, they put a call out to see if any young adults around Galway or the surrounding areas wanted to get involved, and I think around 10 to 15 people showed up, and we discussed what was wrong with the diabetes service, what we weren't getting out of it, what we wanted to get out of it, how we thought we could improve it. And following on that, 8 of us were selected to sit on the young adult panel. And from this, we've had feedback. We've been able to sit down with, the healthcare professionals and Professor Dean and other people involved in this research, and really kind of give some comprehensive feedback on the service and on what is the best way to move forward with it. I suppose at the start it was a very challenging experience for all of us. 8 of us, we were all college students or working, and none of us had any research experience. So we came along to this, and we didn't know how much to say. Were we going to offend any of the healthcare professionals there if we said, this isn't really working for us? You're not really kind of serving our best interest right now. And I suppose as we developed as a group, we undertook different training, research training, qualitative training, different things like that. We became more comfortable as a group. We grew together, and we could provide some really key feedback as to what wasn't working with our diabetes services. In the group of 8 of us, most of us were attending the Galway clinic here, but we did have a couple of people. I myself was attending the Sligo clinic. Before that, I was diagnosed 5 years ago when I was 16, and I'm from Sligo originally, so I was in the clinic there. And Michelle, who's in the audience as well, she was attending Letterkenny, isn't it? Letterkenny. So we could give kind of idea of what was happening in other parts of the country as well. And we found that the exact same problems were happening. Not seeing the same doctor, the same consultant, getting different feedback from different people on the same day, not really seeing a dietitian unless it was once a year, and it was kind of a necessary thing that you asked to see. And a lot of the time it was a very clinical process. You went in, you gave your blood sugars, you got your HbA1c, you left. There was no real kind of talking about what else was going on in your life, what else was influencing why your blood sugars were bad, or why they weren't maybe meeting the standard that was required. And I think the youth panel really helped to open up that dialogue between the healthcare professionals and the young adults, and identifying that there's different areas that needed to be addressed within the clinic as well. Going to college can be a very challenging experience for young adults in general. Having type 1 diabetes can make that even more complex. So having that that bit of advice there that we could put something in place for future clinics that young adults could come in and be like, I'm really struggling with college, and you know that the help is there for them. As well as with the youth panel, you know, we get to help a lot with going to these kind of conferences and, you know, helping with the output of the research. So we've presented at a number of different conferences, including the CRE Integrated Conference it was in Westport last year, and it was in the Connemara Coast Hotel this year. And you know, that was an opportunity for the young adult panel to talk to GPs as well as healthcare professionals in hospitals, and, you know, kind of tell them as well about the different struggles that we were having, and trying to get a more integrated approach between GPs and consultants to tackle type 1 diabetes care for young adults. It's traditionally an area or an age group specifically that's kind of falls to the side. It's kind of that intermediate period from when you've become an adult, but you're not really classed as a full adult yet, because, you know, you're still in college or you're still at home living with your parents. So it's typically an area that's kind of left unaided a lot of the times. And you go to your GP, and you may not necessarily have seen them. You're going for, you know, you've broken your wrist or something like that, or you're going in for something completely diabetes unrelated, and that's what they make the whole visit about. So there's no kind of cohesion there between, you know, your type 1 diabetes clinic and your external medical care from your primary care, which is your GP. So, you know, the young adult panel got to really get involved with that and show GPs, you know, you need to get involved in this process as well. You need to be putting in some advice and sitting down with young adults and seeing what they want out of your care as well. So back to just the training that we got as a youth panel. Again, as I said, we're not researchers, we're not you know, trained in any of these things. So I think it was a very challenging experience for a lot of us to, you know, be able to contribute in the way that we wanted to contribute. I think it was something that we had to, you know, learn on the job, and as 8 of us, it's a lot of people with a lot of different ideas. And I think in the last number of years with, you know, Mary Claire and Professor Dinneen and things like that, sitting down with us and going through, you know, what's good research, what's bad research, how best to convey our ideas, I think that's really helped to focus in on the project and what actually needs to be done for young adults and what we can actually contribute to the service and how we can best improve that. And I think it's a really good idea to involve, you know, patients in research like this, because we are the users of the service. We see what's wrong with it. We can, you know, give our own life experiences of what's worked for us and what hasn't worked for us, and hopefully try and improve that for future generations and future young adults. I don't think there's anything else.
Brilliant. So just 2 minutes. I just want to acknowledge some people who've been very, very involved in making this project work. But first of all, I was trying to figure out a way of giving you an idea of what we're talking about. And last Tuesday, or an evening last week, I sat in on our young adult panel working with Mary Claire and Lisa. Mary Claire O'Hara is project managing this work, and Lisa Hines, who's not here, did a PhD with Molly on non-attendance at young adult clinic. She's a health psychology PhD now, just recently conferred, and I was blown away at how I was really an observer at this session. But so we're doing a thing called a discrete choice experiment. It doesn't project well, but it's something that comes from the world of health economics or the world of economics, where you present people with an interest in an area with attributes, and then you get them to look at different versions of, say, the attribute. That sounds a bit, that's complete jargon. So, you know, where should we hold the clinic? In the hospital, out of the hospital, somewhere neutral, you know? Should we do A1C before, during, or after? Should we, you know, should you see the same person or different, you know? And that's what we're doing. And I sat in on this, and it was just phenomenal. So this is a sample choice card. Again, you can't read it, but I think you get the idea. And it was, to me, it was an incredible example of PPI, of this thing, you know, that we're talking about today, of you know, patient involvement in research. And it was really, really strong. That's what I'm trying to get across. So we have a conference funded through a KEDS award, Knowledge Exchange and Dissemination Scheme award from the HRB. which we're holding here in NUI Galway on the 23rd of June. If you find this topic interesting and engaging, I would encourage you to come along. We have a star-studded lineup of people from across the globe in terms of engagement and self-management support, the role of technology in supporting young adults living with type 1, and then innovations in service delivery. So thank you to, and we have an expert panel and a hackathon, and we hope at the end of the conference to have our heads around the intervention that we can then bring to the next stage and bring back to the HRB. So many thanks. I should have highlighted a few people on this slide, but Mary Claire, I've mentioned, has been driving this project and a huge part of the success. Lots of collaborators, including our colleagues in Jigsaw, Molly, and the Health Behaviour Change Research Group. Lisa Hines I mentioned earlier, but I think in particular our young adult panel, and in particular today Kira Kay.